It's very nice to be here with you all today. I'm so blessed and privileged. I'm going to be talking about designing mental health care upstream, and that's a really interesting topic to follow the conversation on lifestyle gaps that we just had. The one thing I wanted to start with is who I am. So my name's Megan Jones. I'm a psychiatric nurse practitioner, board certified, and a DMP candidate in systems level healthcare. So a systems level approach means that I'm looking at how our health system is designed and how we can redesign the system to better meet women where they are. And the interesting thing about me is I shouldn't be here at all. I shouldn't be here specifically at Yale University because this was my #1 pick school when I was in high school. And I did work very hard, and I got really great grades and whatnot. And I wanted to be a surgeon. I wanted to go into general surgery, but life had other plans for me, and I took a year off. I took a year off to become a surgical technologist. And in that leap year, because I was like, hey, if I'm going to spend a bunch of money on surgery, I'm going to make sure I really like it, right? It's going to be a long time. And so in that in-between year, I found out that I was pregnant with my oldest daughter at 19. So I was a very young mom, and that's not the only thing that I mean when I say that I shouldn't be here. It means here, alive. So I was a young mom, and then following becoming a young mom, my daughter and I were held at gunpoint. We were carjacked when she was 8 months old, and that caused a lot of PTSD. And then following that instance, I developed very severe postpartum depression, and I was inpatient for 3 days. So a lot of my life had culminated to this moment of what are we doing wrong, and how can we do women's mental health different? So that's what I do now. My goal now is to serve women and meet them where they are, to see them as the people that they are, and to redesign our system to meet women where they are. The downstream model of psychiatric care looks something like this. It's the lifestyle gap that we just talked about. Patients experience stress, then they develop symptoms, and then they move into crisis. They're diagnosed with some medical condition or some psychiatric condition, and then we deliver treatment. Intervention occurs only after that functional impairment. Prevention and prophylactic care is the norm in other aspects of medicine. What does that mean? Cardiology is looking at your cholesterol. We want to prevent that MI, right? Obstetrics, we're looking at preventative prenatal care so that we're reducing the risks for mom and baby. Oncology is doing the same thing with screenings, and endocrinology is doing the same things with diabetes prevention. Psychiatry largely lags behind. In psychiatry, we're not looking at preventative care. We're reactional. So how can we rewrite our system to become more preventative? We just talked about, too, this predictable window. It's not a pattern. In my own clinical practice, so I own a private practice, Stillwater's Women's Mental Wellness Clinic. I specialize fully and only in women. And in my own practice, I've recognized that there is a pattern. There's a pattern to care. There are lifestyle gaps that we can recognize a woman is at higher risk and she's more vulnerable to a psychiatric disorder. It looks like the perinatal period, caregiving roles, career and identity shifts, relationship disruption, and midlife hormonal transitions. At these points in our life, we can expect that women are more likely to develop a psychiatric disorder. Women's psychiatric risk is not random. It's patterned across predictable biological and social transitions. What makes these life transitions physiologically risky? It's that increased cognitive load, it's more emotional labor, it's a lot of role strains, it's hormonal and neurobiological changes, it's reduced support structures. So how do we reframe this? How do we make psychiatry a preventative resource? This is what it would look like. Identifying the stress, recognizing early a woman's symptoms, and then utilizing integrative and functional options. As direct care or cash-based care becomes more common because of providers, we're starting to realize we cannot provide the level of care that we would like to provide our patients in an insurance-based model. Why? Well, because insurance reimbursement requires me to diagnose you with something first. That really limits women coming to me to say, let me treat you before we hit that crisis point. We want to recognize the symptoms so that then we can start an integrative and functional approach. What does that mean? And what would that look like? That would mean recognizing that a woman's in a vulnerable life transition. And when I recognize that she's in a vulnerable life transition, I can then look at her functionally and say, what does your B12 look like? What does your folate look like? What does your A1C look like? We can look at her different blood work and lab patterns to put her in a physiological state to better undergo the stress that we predict that she will undergo. And that's where we're moving towards in psychiatry. Instead of reacting to the crisis, we should be looking forward and predicting that this woman is going to be more vulnerable. And if I can prevent that, I can look at her vitamin levels, her mineral levels, her electrolyte levels, and prepare her physiologically. Reframing psychiatry upstream looks like early identification, anticipatory guidance. So that would be our OBGYNs talking about menopause, talking about perimenopause, what to expect, maybe recommending early psychoeducation and therapy to that woman so that she can prepare herself not only physiologically for that bio change, but that she can also prepare herself mentally for what that change is going to look like. Skill-based supportive and functional and integrative optimization, and then selective pharmacologic interventions when we need it. What preventative psychiatry might include? It might include transition-specific psychoeducation. It might include early screening for certain vulnerability, looking at that client's support network, stress capacity planning, short-term anticipatory therapy, preventative medication consultation when indicated. So one of the biggest thing here is short-term anticipatory therapy. I know there's a lot of therapists in the room, and a lot of you see the same things I do. People come to you when crisis is acquired. But why is it in psychiatry we don't meet women at the bedside whenever they've been just diagnosed with cancer or with a terminal illness? We meet them and we say, this is going to be really hard on you physically. But who's showing up to say, make sure you prepare yourself mentally and emotionally for this journey? That's something I think that we should and could be doing a lot better. Why does this matter? It matters because overall, this can reduce our morbidity and mortality. We can reduce emergency room visits, reducing those hospitalizations. We can improve life functioning. There's less clinician burnout because now I'm not dealing with women in crisis all the time. And it's a gentler treatment. Because when women come to me and they're in crisis, now I'm looking at prescribing benzodiazepines or harsher drugs on her body. If I can get her to come sooner, we can prepare her physiologically for that stress that she's going to undergo. This opens the door to integrative and functional psychiatry. Why isn't this the standard already? It's the fee-for-service incentive, having to have a diagnostic requirement. Something I say all the time is insurance will pay for a crisis, but they won't pay to prevent one, which is a really hard truth. There's a lack of preventative framework in psychiatry. There's a cultural expectation that psychiatry only treats illness. And there's societal stigmas surrounding mental health and treatment options. So how can you, as clinicians, begin to identify where you can meet your patients with upstream psychiatry? Can you identify partners for interdisciplinary collaboration? Begin screening for life transitions. Know the patient is my #1 advice. Know their family, their friends, their support networks. Know what's going on in their lives and know them for the humans that they are. Provide proactive psychoeducation. Utilize active listening models. Integration with OB and primary care and nurse-led interventions are really great tools. So if you take away anything from today, I hope that you can take away that preventative psych offers an upstream model of care, and earlier care opens the door for integrative and functional approaches. This early intervention can reduce crisis and long-term mortality. Some questions I have for you all to consider is, what's one thing you can do in your practice to move psychiatry upstream? What would that look like? What is the difference between relational and reactionary care? And then a really challenging question is, what does upstream psychiatry look like in the inpatient system? Because in the inpatient system, we're strictly kind of dealing with what is going on in the moment, right? But what it looks like is collaborating with who they're going to be with in the outpatient space. Did they have an outpatient provider before they were inpatient? Is there collaboration going on between those two providers preparing for discharge? It looks like understanding and knowing them for the people that they are so that you know their support system and you can better provide them with support and resources outside of the hospital. Thank you. I think we have some time for questions if anyone has those.
Thank you, Megan.
Yeah.
Really appreciate all the information that you had just given us. My question to you is this. I am a mental health practitioner, and I do see patients during life transitions, things that are happening in their life, like a lot of people do. But my question to you is this. How can we get the psychiatrist or the nurse practitioner or the general physician to communicate with a licensed mental health therapist? That's a big challenge that I see.
Yeah, and I think that that's a phenomenal question, actually. I have a lot of issues getting to talk to PCPs and OBGYNs myself, but I think it's the advocacy for your patient, the following up with that provider and saying, I need to talk to you about this patient, that consistent follow-up. I really truly do believe that over time, we have siloed ourselves, right? So there's psychiatry and then there's, primary care and OB, and that has been great because it's allowed us all to develop a depth of understanding in our own specialties that might not otherwise be achievable if we weren't separated like that. But it's also siloed us in the sense that we don't communicate back and forth. And it leaves our patients feeling very, very lost. Because when I have women come to me and I'm asking as a psychiatric provider, when's the last time you've had blood work? Has anyone looked at your vitamin D? Well, they might have it or they might not. But that point of care now becomes my responsibility to reconnect with their PCP and say, this is what I'm seeing, what have you been seeing? And we have to work in that collaborative approach. So I think above all else, to answer your question, it's just advocating for your patient, following through, drive them crazy if you have to, because it's about that patient and it's about their care, right?
Very good. Thank you.
Yeah. Thank you.
Hi, your work is actually very much aligned with mine, which makes me very happy. So I worked inpatient for quite a few years, and I actually noticed that no matter the story or the diagnosis, it was the same skills I found myself teaching again and again and again to my patients, whether it be them not knowing where their sense of value and worth comes from, a lot of external validation, not having any kind of knowledge about what are emotions and any kind of emotional literacy. And I actually kind of ended up developing a framework that will hopefully through research allow me to produce curriculum that can be taught to ages of anyone and hopefully be distributed among schools and community centers and places that, will be able to do that preventative work. But we have a system that is not in our favor. And, working in psychiatry, to be quite frank with you, it was sufficient if I just went in for 5 minutes and just told my patient, okay, here's basic physical coping skills. And are you suicidal or not? Okay, you can be discharged. That was actually the expectation. But I was in there for hours and hours and hours because they needed that.
Yeah.
But the system is not set up for that. It's very much okay, if there isn't crisis, then you're good. We don't need to treat you anymore. So I understand there's a lot of public policy involved in that and a lot of laws involved in that too. But how do you suggest we work with the system other than that individual level? I don't know if you have had any experience yourself And this kind of goes to the keynote, speech at the beginning too, where we work collaboratively to be able to actually like preach that this is what's needed to save money, if anything. Like the amount of money that's spent in crisis is actually crazy.
Yeah.
Yeah.
Yeah, that's a really great question. So I think to start, the most important thing is, as professionals, we're taught we need to have our professional boundaries. Like, this is professional psychiatric Megan. This is mom Megan. I have 4 children. And then this is speaker Megan. And we silo ourselves even in that sense. And in school, we're taught, keep your professional boundaries. Don't let your patients know too much about you. And there's certain amounts of wisdom in that. But what I found has been the most effective and most time effective, I guess that's what we're really concerned about when we're talking about operating in the system, is we don't have, 8 hours to sit down and talk with one patient a lot of times. So we need to cut to the chase. And so what I like to tell my patients is I tell them a little bit about my story and my background. I say, I was a young mom. I survived this carjacking. I also survived a house fire when I was in 6th grade. And then, living through this inpatient time that I did with postpartum depression, and later finding out that I had SLE, I have lupus. All of these things I kind of lay out in front of them, and I say, I don't say that to make this session about me in any way. I'm telling you that so that you know that there's nothing that you can tell me that's going to make me judge you or think differently of you. And I'm here to be your advocate, right? So I think learning how to break down those barriers so that it's not me sitting here preaching down to you or giving you these tools. They need to see us on the same playing field that we're on, right? So that whenever you give them these words of wisdom, it's not coming in a preachy or coachy way. It's coming in as, I'm an advocate and a partner with you in your health. And I think that's the most important thing you can do, is humanize yourself to your patients.
Thank you.
Yeah.
Megan, questions are coming through the chat. Can you re-show the lifestyle gaps where women are higher risk or more vulnerable for psychiatric conditions? And I'm going to go up to another question because I'm curious about your process of developing this upstream framework. So they would love to see your PowerPoint. If you can go back. That is one question. They want to see how, again, I'm going to repeat the question of how the lifestyle gaps and where women are higher risk and more vulnerable for psychiatric conditions, and learning about the process of this framework.
Yeah. So I guess the biggest process of this framework is hormonal. We know that our hormones interact directly with our psychiatric health. So understanding predictable periods where women are mostly at risk would be puberty, peripartum, and perimenopause, because these are major transitions in our life where we will see hormone disruption. And then as a result of that, we're more biologically vulnerable to stress. So it's not necessarily true that you will experience this stress, but it is true that you are more vulnerable at those moments in your life. So we look at that as the foundation. And then secondary to that, we look at life and situational stressors. So if you have a woman that might be going through perimenopause and she also is going through a divorce, she is twice more likely to be at risk for whatever psychiatric condition. If you have a young child that's going through puberty and has also moved states and is in a different school and has lost all of their social support network, now they're twice as likely to develop some sort of disorder. So getting in front of that means providing anticipatory therapy, knowing that they're at higher risk, even if they're not necessarily exhibiting symptoms at this moment, and getting in front of that stress. Additionally, then we can look at the blood work and say, okay, this woman going through perimenopause is at high risk. She's going through a divorce. She's also taking care of her aging mother. Let me look at her lab work and make sure that her B12 and folate are square, that her vitamin D is looking good, because if it's not, now we're just kind of undermining ourselves biologically and putting ourselves at further risk, if that makes sense. I hope that answers the question.
Yeah, no, that was very helpful and answered it. Is there okay, there's 2 questions here, and we'll end with those 2. Is there any aligned work in helping patients advocate? It seems that there's multiple connecting points that would help raise awareness and understanding. I'm going to repeat that one more time. Is there any aligned work to helping patients advocate? It seems that there are multiple connecting points that would help raise awareness and understanding.
Yeah, for sure. There are so many, there are so many jumping off points. One of those, and one of the biggest ones, would be access. So my doctoral work, like I briefly mentioned before, is in systems access and equity. And so what I'm doing, as we all are moving, not all of us, a lot of us providers are moving towards direct care. We're looking at more cash-based prices. I do this so that I can spend a larger amount of time with my patients, right? I can spend an hour with each one of them instead of less amount of time. And then I can see less patients and really spend all my time focusing on the patients that I do have and serving them well. But what we have to look at as a society and as providers is that inadvertently causes a disparity gap, right? Now that I'm charging cash. So I'm saying there's going to be some women that can afford care and there's going to be some that cannot. So my doctoral work is all about cross-subsidy revenue to providing care. So what I do to kind of mitigate this system is, on my website, I sell other products. I sell vitamins, I sell shower steamers, I sell bracelets, I sell teas, and then I use that revenue as a sliding scale fund for women that come to me that can't afford care. So if they can't afford to pay me, I pay myself from the products that I'm already selling, right? So that's a model that my doctoral framework is like surrounded by. But the point there is we need to get more creative. Mm-hmm. We need to get more creative with how we're funding care and be less willing to say, well, I just don't have enough time to take care of this patient, so I'm just going to do the best I can. We need to say, this is the quality of care that I'm expected to deliver, and I want to do a good job, and how do I make that a reality?
Here's our last question. I work in an impoverished area where access to care is limited by insurance coverage and lack of available providers, 6 or more wait, among other factors. How do we bring preventative measures to these areas?
Yeah, that's a great question. That's a health system problem. And it goes back to, again, insurance coverage. And the problem with preventative psychiatry is going to be we're already at a work shortage in the psych field, right? So now if we want to open it up to providing care for women in a preventative capacity, that's going to become challenging because we're struggling to take care of the women that are already in crisis, right? That comes back to our interdisciplinary and collaborative approaches, really relying on our PCPs, on our OBGYNs to recognize and start this preventative metric and training them outside of our field to recognize those things. The other question there is, how do we provide care with limited resources and limited time? And I think that really comes down to Dr. Stephen Treziak. I don't know if anyone's ever read the book, Compassionomics. Anyone read that book? It's a fabulous book, and it's all about compassion fatigue and connecting with our patients, the human factor, and bringing basically compassion and humanism back into medicine because we've lost a significant amount of that art. It looks at not necessarily the time that we have, because it takes 40 seconds in his research to make true compassionate connections with your patients. So it's not, in this instance, looking at how do I get more time? It's looking at what can I do with the time that I have? And that's connecting with your patients and saying, I see you, I hear you, I want to help you, I am here for you. Making that your priority to connect with the patient as soon as you enter the room. That's what we do while we can, work to redevelop the whole health system in the meantime. All right, thank you.